null position in down or up gaze is not because they have upbeat or downbeat nystagmus, as opposed to acquired. It's because they have infantile nystagmus with their eccentric null position down. I don't know why it's down, right, up, or left, but these are mostly associated with afferent system disease, optic nerve and retinal disease, as we saw with the SOD kit. Can medications affect them? Sure, the medications we've been discussing the whole time can be tried, because we're not treating the chin up, we're treating the INS. So here's my heart arrhythmia on EKG, and here's my beta blocker treating my heart arrhythmia. It's the same with this. Here's the eye rhythm abnormality. Here's the medication that treats that rhythm abnormality. That's the way we're trying to make it more modern, more like modern medicine. This is what happened in cardiology, at least in the United States, in the 1920s to 40s. People would go to 2 or 3 places, get their heart recorded, and they try and figure out how to change the EKG waveform. But around the rest of the country, they just put their fingers on the pulse, give them something to chew on, check the pulse again, and I think you're going to be all right for another hour or two. You'll make it home. That's the way it was, and that's the way it is until we can, we're on the cusp of this.
This is a 8 years female patient, came with a complaint that she cannot see the blackboard even from the front row, and she has unsteady eyes. This is her photograph. Visual acuity, she is binocularly 0.7 logmar and uniocularly right eye is amblyopic. This is her video. She maintains slight seeing count, though not significant.
Is significant. That's my point. Why isn't it significant? That's where I want the thinking to be changed.
She has alternate esotropia, 30 prism diapers.
Look, she's trying to put her chin down. You hold her head up with the occluder.
And no convergence damping.
Yeah. She's trying to put her chin. Look, her eyes are way up in the top of her orbits, right?
Yes.
Yeah. I mean, why would she? She's looking at near. What do? We look down at near, and this child's looking up. This is typical for albinism. This oculocutaneous albinism. They have a chin. I was just in China, and I saw 70 OCA1 patients, 70 families with OCA1, blonde like this. And I have a picture of all of them. They're all like this before I saw them. They're all lined up, and they're all like this. Yeah. Is there any doubt? We reported this years ago in multiple places that they really have chin down nulls. They really respond to operation number 2 very, very well. Very well. We just did one here in Hyderabad the other day. This is a very common operation. I did 45 operation number 2s on all of those patients. And you can treat her strabismus at the same time, BMR recess, BIO, and BSR. Really good. Yeah.
She had foveal hypoplasia. And apart from this, what will be your suggestions for her?
Yeah, I would do more than the squint correction. I would do the bilateral superior rectus recession and inferior oblique myectomy with the BMR recess. Give her the tinted contact lenses, and make sure she doesn't have PAN too. APAN. 33% of albinos will. So usually for these patients, they get baclofen, peripherally tinted contact lenses, and eye muscle surgery. Many of these patients require baclofen because they'll have a PAN or APAN component.